Hi, you may have just been diagnosed with cervical, endometrial, or ovarian cancer, which are all types of gynecological cancers. If you have, please stay tuned, or if you're just interested in the topic, as we discuss this on Focusing on You. Hello, my name is Lisa Cawthorn. I'm a volunteer with Hope Abounds. I serve as a patient advocate, and then I'm also an oncology nurse and a breast cancer survivor. So this evening, we're going to talk about gynecological types of cancer, which is a mouthful, so we'll explain as we go a little further along. We're very lucky to have one of our local gynecologic oncologist here from Wilmington, North Carolina, Dr. Walter Gajewski. I want to tell you a little bit about his background before I turn to him and we discuss some things with him. So his expertise is in gynecologic oncology and robotic surgery, which we'll learn a little more about. He went to Georgetown undergrad and the Medical University of South Carolina in Charleston, South Carolina for med school. Did residencies back in Hartford, Connecticut, and a fellowship at Massachusetts General Hospital, also known as Mass General, and Boston, Massachusetts. So I want to welcome you, Dr. Gajewski. It's
Thank you,
great
Lisa.
to have you here. And I understand some of your patients might call you Dr. G sometimes.
Most of them call me Dr. G.
Most of them do.
That's right.
But thank you so much for taking time out from
My
your
pleasure.
busy schedule and joining us. And I always think it's interesting because gynecologic oncology is very specific.
Mm-hmm.
And you also sort of wear several hats in that role compared to some of the other folks that I've interviewed. We've interviewed medical oncology, radiation oncology, surgery, pathology also. So tell me a little bit about your personal philosophy of care, and then we'll go into more about what you do.
Okay. Well, I'd like to first say that I'll give you a little bit of background in what gynecologic oncology is.
Great.
And it is a subspecialty of obstetrics and gynecology. And all of us have to train in obstetrics and gynecology residency prior to doing fellowships in GYN oncology. But the interesting thing about GYN oncologists is that we're trained to deal with patients in all areas of their paths through cancer. So we deal with the diagnosis of the cancers, we deal with the workup. Ultimately, if there's surgery, we do the surgery. If there's chemotherapy, most of us do the chemotherapy ourselves. And then we partner with the radiation therapist very closely to give radiation therapy when that's indicated for the disease. We also are trained to deal with patients as an ongoing basis in their follow-up. If they recur, we see them, and then ultimately, if they are going to succumb to their disease, then we deal with their palliative and care and comfort as well. So I look at it as more like a primary oncology rather than just gynecologic oncology. Mm-hmm. We don't do all of the medical oncology that those subspecialists would do, but we basically take on the patient from the beginning and help monitor them and keep them through the process.
So then what does gynecologic oncology mean? What types of patients are you treated? What type of cancers do you see?
We see patients that have any gynecologic cancer, which are cancers that arise from the female reproductive tract.
Okay.
There are some G1 oncologists that are trained to treat breast cancer, and we always kind of laugh that somehow the breast got separated from the rest of the gynecologic or female organs in terms of reproduction. But be that as it may, we treat women that have ovarian cancer, as you said, uterine cancer, cervix cancer, vulvar, and vaginal cancer. We also deal with patients that develop gestational trophoblastic disease that is considered potentially a form of cancer, and other difficult surgeries that may come up relative to a patient's pelvis. We're expert surgeons, if you will, and we deal with a lot of difficult surgical situations that other OBGYNs may not be comfortable dealing with.
Right. So when you are doing surgery, you may not even know if it is cancer or not.
Yes.
But you're still doing a surgery, and it may turn out to be benign or not cancer. Is that correct?
Yes.
When you're
Yes,
doing
absolutely.
what you do?
Mm-hmm.
So you said you typically do the surgery, and then you take on the role as medical oncology for chemotherapy,
Mm-hmm.
typically. So you're seeing the patient. So you mentioned the types of, and I'll shorten it to GYN cancers. That
Okay.
might
Yes.
sound a little easier. And then who else is on the team that you work with, whether it's in your office or in the medical community? Who else are you working with then?
Well, we are part of a cancer center here in Wilmington at New Hanover Regional Medical Center. So we have complementary and ancillary care groups that help work with us in far as taking care of patients. So we have a staff that's in the floors for their inpatient treatment that are trained in gynecologic oncology and used to treating women in gynecologic oncology problems. The Women and Children's Hospital is designed for mostly women, so they have their own floor, if you will, where they can be cared for as inpatients. And then in the office, we have nurses who are usually certified nurse oncologists, and we have medical assistants that help with the routine care of the patients. Mm-hmm. But we also have nutritionists, social workers, dietitians, and just ancillary people that, and we have a healing arts program as well that can deal with patients that may need help with other things, such as massage therapy or lymphedema therapy and other things that may be needed for them.
Great, great. So if you can sort of walk us through maybe the different types of cancer and what potential care plans might go along with each patient. So maybe a lot of people haven't heard of some of the cancers that you're talking about. I think when you say breast, almost everyone knows someone.
Yes.
Or knows someone who's had breast cancer. It's very visible. It's the most common cancer in women. Mm-hmm. But the other cancers, maybe not so much. So if you could maybe walk us through each of those cancers and talk about that a little, that'd be great.
Do you have 2 hours?
Yeah, I know. All within like a paragraph or two.
Well, we see, as I said, mostly gynecologic cancers in the pelvis. So the most common type of cancer that we see is endometrial cancer.
Okay.
And that's also called uterine cancer, but there are cancers that arise in the wall of the uterus that are muscle tumors or sarcomas that are really considered different cancers than the endometrial cancers that we see. But the endometrial cancers are by far the most common that anyone sees, at least in this country.
And what age group would we be talking about typically?
The peak age is in the mid-50s.
Oh, wow.
So basically, usually right after menopause, interestingly enough. It's fairly rare in women under 40, but it sort of peaks in the mid-50s. And a lot of those cancers are considered due to an imbalance in estrogen and progesterone in a woman's system. And that leads to an overgrowth, if you will, that can be precancerous and then ultimately cancer. Mm-hmm. So there's about 50,000 cases a year of endometrial cancer in this country, and the nice thing about those endometrial cancers is that there are early warning signs, and most of the time those warning signs lead to a diagnosis early in the cancer. So women that have bleeding that's irregular, and after menopause any bleeding is abnormal, so it needs to be evaluated, even if it's spotting. But once we know that there's bleeding or abnormal bleeding, then a biopsy is relatively easy to do of the endometrial cavity.
Is that done
And
in the doctor's office or somewhere else?
it can very easily be done in the doctor's office.
Okay.
Sometimes you have to go to the hospital and have a D&C, but most of the time you can get a good biopsy and get the results.
Okay.
And once we find that, as I said, 3/4 of the time those women are going to be diagnosed with stage 1 disease, which means the disease is contained within the uterus itself.
So very early stage
Yes.
disease.
And that speaks to surgery as the primary treatment for those cancers.
Okay.
So in those women that have uterine cancer, surgery is usually the first step as far as the treatment goes. And then depending on the variables, the risk factors, if you will, for metastatic disease or recurrent disease, then we decide whether or not any adjuvant therapy or additional therapy after surgery is indicated.
So if they were past the first stage, an early stage, what other type of treatment might be appropriate for them?
Well, historically, it was radiation therapy that was done after surgery.
Okay.
That was because we really didn't have what we thought was good chemotherapy to try and treat disease that might be outside the pelvis or spread beyond the local area. But now that we have some newer drugs that have really been felt to be effective, we assess the risk of local recurrence in the pelvis and the risk of systemic or metastatic disease outside the pelvis, and then try to tailor an adjuvant therapy for that. It may include just radiation, it may include radiation and chemotherapy, or in women that have metastatic disease outside the pelvis, either at the time of diagnosis or later, we would treat them with just chemotherapy.
Okay.
So it depends on those risk variables that we acknowledge and check on.
So the fact that most cases are early stage is very encouraging because it would be a simpler surgery, most likely,
Yes.
and then maybe not any other therapy after that because except for follow-up with you, of course.
Right.
But you had mentioned to me before we started the interview that endometrial cancer is on the rise in the United States. And most people are under the impression that we're getting a better handle on cancer. We're determining what treatments and we're trying to figure out what causes it. So why is endometrial cancer on the rise in the United States?
Well, most endometrial cancers develop as a result of that imbalance in the hormones, so the imbalance of primarily estrogen and progesterone in a woman's system. And what we know is that obesity and diabetes can affect the ovary and the ovary's function in producing estrogen and progesterone in a cyclic fashion that controls the hormone levels, if you will, and the result of the hormone levels in the body, in the uterus itself. So we're seeing a rise in endometrial cancer, we feel primarily because of the increased incidence of obesity and diabetes in basically, our country and other developed countries.
That's true.
And we don't, we probably have more obesity here than in a lot of other developed countries, unfortunately.
So watch your weight and try not to go in the wrong direction, which if I remember correctly, I remember one physician saying to me, post-menopause, a lot of women gain an average of 2 pounds a year, which was very discouraging. So you have to work harder too to keep the weight off. And since that's the population that you're typically seeing, it sounds like that's another factor. So to be conscious of any postmenopausal bleeding and to try to keep your weight down.
Yes.
Right?
Yes.
Okay. And then moving on to cervical cancer, would you describe that a little for us?
Cervical cancer is about 10 to 12,000 cases per year in this country, so relatively low numbers. And as most people know, the Pap smear is the screening tool for precancerous cervical disease, cervical dysplasia, or even cancer itself of the cervix. But it really works well at identifying precancerous changes on the cervix that can be treated before it becomes invasive cancer. And that's why the rates have gone down dramatically, and pap smears were developed in the 50s and really changed the incidence of cancers of the cervix in this country and in the developed countries. It's worldwide, though, probably one of the leading killers of women because of the lack of screening and the lack of pap smears and the ability to act on those pap smears in those populations. But we do fortunately have a good way of screening for it, and that's with the pap smear itself. We've been changing our recommendations for when pap smears are done. And
That's
I
what
know
I
you
was
were
going
going
to
to
ask you. What's the recommendation? And the reason those recommendations tend to change, it's usually a nationwide panel of experts that come together and they look at all the research and the statistics, and then they adjust because of that. Is that?
That's exactly right.
Okay.
And this has been looked at in a number of ways by a number of different groups. And there are some differences of opinion in terms of how often women should be screened. But right now, the recommendations are for women to start getting their pap smears at age 21.
Okay.
And then depending on the results, if they're normal, they can be screened either every 3 years or every 5 years, depending on whether they're going to do HPV testing or what we call co-testing, the pap smear, which is a cytologic evaluation plus the HPV testing. And that can be done every 5 years. And that continues on that schedule usually until the mid 70s, and then it's felt that you can stop if you've had normal pap smears. If you've had a hysterectomy, and you've never had an abnormal pap smear, then you probably don't need to have pap smears after a hysterectomy. But in the middle-aged population, if you will, screening is still important.
Okay.
Okay. And smoking is something that women should avoid because we know that smoking increases the risk of cervical dysplasia, which is a precancerous change, and cancer itself. So smoking is a no-no as far as that goes. The women that get pre-invasive disease or dysplasia, they need to be screened more frequently.
Okay.
And so they're watched more closely. The reason and the rationale for changing the recommendations for pap smear screening was that, one, we believe that there's a precancerous changes that go on that can last for years, anywhere from 10 year up to 10 years before the cervical dysplasia could become an invasive cancer. And what we did when we previously were screening women whenever they started to be sexually active, or at say 16, we were finding some of these precancerous changes on the cervix that were minor, but we were still acting on those and either doing ablations or small cone biopsies of the cervix, and ultimately changing the cervix enough to put future pregnancies potentially at risk, and were more invasive than we needed to be.
Gotcha.
So we tried to cut back on the amount of interaction we're doing in younger women, where a lot of those mild changes will go away on their own with time.
Wow.
Because HPV causes cervical cancer, and HPV is a sexually transmitted disease. And almost all women are exposed if they're sexually active. So it's something that we recognize, but again, can be screened for.
So, since you brought up HPV,
Okay.
sometimes it can be controversial. What is your take on the HPV vaccine, since you just related to cervical cancer?
HPV, as I said, causes cervical cancer. There are over 100 different virus subtypes of the virus, HPV, and they've been subclassified into high risk and low risk subtypes. So we know that there are the low risk subtypes that cause like warty changes in venereal warts, and then there are the high risk subtypes that are actually considered to be related to cervical cancer, and the most common are HPV 16 and 18. The HPV vaccine attacks or is meant to block 4 different subtypes of HPV. The 6 and 8, which is the the low risk subtypes, and then the 16 and 18, which are the higher
high risk.
risk subtypes. And we know that the vaccine is very effective at stopping those subsequent abnormal changes on the cervix. So we know that it will decrease your risk of cervical dysplasia and ultimately cancer. So I think it's important that we continue that, and that women and men should be vaccinated, because again, men are the vector, and if men don't have the HPV, we block that by vaccinating them, then we're also going to decrease the risk of spread of HPV.
And what's the recommended ages to get the HPV vaccine?
Usually after age 10 or 11, and as young as 9. And women that haven't had HPV in their system or don't have those 4 subtypes of HPV vaccine can be vaccinated at any time. But usually, as I said, as you get older and you have more exposure, by the age of 30, you're more likely going to have the HPV anyway, and the vaccine isn't going to be that effective.
Okay.
But we still vaccinate some women in that case, because they may have, say, HPV 16, but don't have HPV 18, and the vaccine would help as far as that goes.
So how would they test to know someone had HPV? Is it a blood test, or is it looking at the cells from the cervix?
They can look at the pap smears themselves, or
Okay.
and determine which HPV, whether there's high risk or low risk subtypes in that specimen.
Okay, very good then. And that may prevent much of the cervical cancer.
It'll help reduce it further. The incidents have been pretty stable in this country for a number of years because of the screening that goes on, and quite honestly, I think the numbers still hold up. But we used to say that up to 50% of women that have cervical cancer, invasive cervical cancer, have not been screened in the prior 5 years.
Wow.
So it's women that don't get the screening that we recommend that are at higher risk, because we're not picking it up early enough.
So pap smears are very important too.
Yes.
Yeah.
But having said
what
that,
age are we talking about for women that end up with cervical cancer? What age range is that then?
well, usually it's in the early 30s,
Okay.
but we've seen it in older women, and there's really any number of age group that's at risk. But the younger population is, as I said, is less likely to have invasive cancer.
Okay.
But there are exceptions to anything, and I've seen cases with young women that have had invasive disease and advanced invasive disease. But fortunately, if it's caught early, and so if women are screened, and even though if they develop cancer, if it's early, then surgery can be a treatment that works well for those women, and the majority of those women will be cured with surgery or surgery and radiation therapy. In advanced disease, we use primarily radiation and sensitizing chemotherapy with their treatments, which also can be very successful. So,
Okay. And what are some of the signs and symptoms of cervical cancer then? You said it could be picked up on a pap smear, and I'm assuming a GYN exam would
Yes.
be another way to, a physical exam. But how would a woman know that maybe she needed to see her doctor?
I think the major things would be if they had irregular bleeding or spotting,
Okay.
if they had any spotting with intercourse, that would be unusual. Pain in the pelvic area would be something that would be a warning sign. The problem is that in the early stages, grossly the cervix is going to look normal. So any visible lesions on the cervix should probably be biopsied, but early disease that is relatively early, you may have a cervix that looks normal on visual exam, but the pap smear would pick up an abnormality microscopically. So that's important.
But if you compare and contrast that to endometrial/uterine, it kind of depends on what you're calling it. It sounds like the endometrial uterine group is postmenopausal, so if they're having bleeding, they should be concerned.
Yes.
But if you're in a younger group of women, it's still possible to get a cervical cancer, maybe, but they would still need to be conscious of any sort of irregular bleeding in
Yes.
that group too, or pain,
Mm-hmm.
things like that.
Right.
Okay.
Exactly. Discharge, any abnormal discharge, that would be something that also to look for.
Okay. And now going on to one that is, well, all cancer is serious, I'll say, but ovarian might be a little scarier because of the statistics involved. Can you talk to us about ovarian cancer? I used to tell women, I used to say, if you think the reason why we don't find out about ovarian cancer early is if you think of the ovaries being the size of an almond. I said something really has to go wrong in
Right.
order to figure out what's going on with that. So could you talk about ovarian
Sure.
cancer a little?
Yeah, ovarian cancer is certainly probably the most compelling disease that we have to deal with, and primarily it's because it's the most deadly disease that we have to treat, and the reason for that is probably because we can't diagnose the cancers early enough, and there's debate about whether or not the early cancers are really have the same biology as the later advanced stage cancers, but unlike uterine cancer, where we have early warning signs, or cervical cancer, where we have a screening tool to screen for either the cancer or the precancerous changes, we don't have a screening tool for ovarian cancer. The numbers are about 25,000 cases a year in this country, so about half the incidence of endometrial cancer that we see. But 3/4 of those women that have ovarian cancer are going to die of their disease. So that's where it becomes hard.
So
It's like-
3/4, 75%
yes,
of the women who get ovarian cancer are going to die of ovarian
yes.
cancer. Okay.
And that's, unfortunately, that's the case. And that's because we
devastating.
don't diagnose it early. And most of the time, when a woman's diagnosed, they're in what we call stage 3 disease, which is disease that's outside the pelvis into the abdomen. And that's the majority of the patients that we see. 75% of those women are stage 3 at diagnosis. Having said that, though, the treatment that we have is very much better than it used to be when I first started 30 years ago. We have treatments that are very effective at controlling the disease and in curing the disease in 25% or 30% of the women. And that is something that is a good thing, quite honestly. There's a lot of work that needs to be done, and we certainly have a lot of work that goes into ovarian cancer, even though they're relatively low numbers. And that's because it is such a compelling disease. But the reason we don't have early warning signs is that the ovaries are in the abdomen. You can develop a cyst or a mass on the ovary, and it can become quite large before it's detected because there's a lot of room for things to move around. And what I tell patients is that when you were pregnant, your uterus got to be, up to your belly button basically before you even knew that you were pregnant most of the time, at least for your first pregnancy. And the only reason you know that is because when you had nausea or you felt lousy or your periods were stopped, so you didn't have a period anymore. And so, and imagine an ovary where your periods are still going to be there if you have still having your periods, and that ovary can grow and it's innocuous. You don't have any symptoms from it. But when it does start to spread, you can develop GI symptoms, basically, are the most common things. Gastrointestinal disturbances, where you may have nausea, have bloating, have a change in your bowel habits. You might feel like your abdominal wall is swelling, and that could be from the disease. It could be from fluid buildup in the abdomen that often comes with the advanced disease, and that's when these women unfortunately get diagnosed. And because these symptoms are very common for women in that age group, and the incidence of ovarian cancer rises as the decades go on. So the incidence is highest in the 70s, basically in the 60s and 70s, seventh decade. So those women commonly have those kind of problems.
Right.
And so they frequently go to a gastroenterologist or whatever who looks at their colon and anything else, and you don't see anything. So
Well, actually, they're probably starting out with their primary care,
Yes.
and they're probably trying different medications
Yes.
to see if that helps. And then the primary care says, "Oh, well, let's send you to gastroenterologist." And then the gastroenterologist may even try some different medications before doing diagnostic tests.
right.
So, what diagnostic tests would actually show what was going on in the abdomen then?
Well, what we recommend for women that have symptoms like I just described that last longer than a few weeks or so, that drag on for a month or so, that they should talk to their physicians and ask for an ultrasound of their pelvis, their ovaries, and consider getting a CA-125 blood test, which is
Okay.
a tumor marker that we use for patients that have ovarian cancer. And 80% of women that have ovarian cancer, epithelial ovarian cancer, and I'm making a point of that, is that there are more than 20 different cancers that start and can exist in the ovary, but epithelial ovarian cancer, which is the most common, are the ones that are truly the hardest ones to treat. So in those women, 80% of them will have an elevation of their CA-125, which is a molecule that's in the blood that we can measure. And we've known about this for 40 years or so. And it was felt when they discovered it that, well, if that's the case, then why can't we just screen women with this blood test and identify something that is an early warning sign or an early detection device for ovarian cancer? The problem is that it's not specific enough for just ovarian cancer, that there's a lot of conditions that women have that elevate that blood test.
Especially if women are in their 70s and they may have other.
That true, but
Issues
it's more
going on,
commonly
right?
actually in the younger population. So it's the younger population that have fibroids, that have endometriosis, that have inflammatory conditions that might lead to that. So all of those conditions that are benign can elevate the CA-125. So in women that were considered high risk because of family histories of ovarian cancer or breast cancer, we used to screen them with ultrasounds and CA-125s every 6 months. And what we realized is that we could diagnose some of those cancers before they were symptomatic, but a lot of them were already advanced stage, so they hadn't reached the symptomatic stage yet, or they were too small to be recognized. And what you'd have is 10 operations to find one cancer, because you're screening them, you're finding abnormalities in their ultrasounds, you're
You have to
finding
chase it
abnormalities,
down.
and you have to follow up on that. So in order to find one cancer, you'd be operating on 10 women to try and find them for otherwise benign conditions. So we still recommend that on a certain level, but we ultrasounds are better than they used to be, and abnormalities that are detected on ultrasound should probably be followed up, in that way.
So you mentioned family history.
Yes.
Could you talk about family history a little bit and genetic mutations that are associated with ovarian cancer?
Sure. We know that as I said, ovarian cancer and breast cancer are linked in a way that if you have breast cancer, you're more likely to get ovarian cancer and vice versa. And in women that have family histories of other first-degree relatives that have ovarian cancer or breast cancer, then we know that their risk of developing cancer is also high. And a lot of those women have been identified as having a mutation in their genes, and specifically in their BRCA genes, which is BRCA1 and 2. And we can screen for those mutations in patients that have a family history or a strong family history
With the blood test.
For the blood test.
Right.
Actually, it can be done on saliva as well now, but there's a way of testing that in the blood. And it used to be felt that about 10% of these cancers were actually caused by mutations in the genes. That because we're testing more and more women now for BRCA mutations, we're finding that the incidence is actually higher than the 10% that we initially thought.
Oh, wow.
So it's probably on the order of 20 to maybe even as high as 30%. And that's because now we're recommending testing on every woman that's diagnosed with ovarian cancer. Before, it used to be just if you had a strong family history, in addition to your own disease, or if you had a family member, a first-degree relative that had the disease, and they were tested positive, then you would be tested as well. So it's something to identify whether that's really a genetic problem, but still most of them are sporadic diseases, sporadic changes in the genes that cause that. And ultimately, with time, we're probably going to identify other mutations
Right.
that haven't been determined yet or
So the
discovered yet.
advantage of all cancer is a genetic mutation, but sporadic means within your own body you've had gene changes, right?
Yes, exactly.
Versus if you had a genetic mutation, a marker like BRCA1 or BRCA2, which caused a mutation, that would be passed down. Also, it could be passed down to your own children. So that's
Yes.
part of why that's important, is that
So there's genomic mutations, which are the ones you just described, or you inherited that from your parents, or you can have a somatic change, which is where the cancer itself has mutated and caused those. And within that cancer, there's a gene mutation that is actually allowing that cancer to be malignant and to grow in that fashion. But the important thing about those mutations now is that, and this speaks to what's on the development phase or on the threshold of treatment now, is targeted therapy, where we can actually screen for a number of different molecular markers or genomic testing, either for mutations or for abnormal proteins that are expressed by the cancers, and look to those changes as a target for therapies that will help to control the disease and the cancer growth, and that's where we're heading. And BRCA or BRCA is one of those mutations that we know that if it's present in a woman that has ovarian cancer, that the new drug line of PARP inhibitors, it's again looking at a change that goes on in the cells themselves that allows the cells to fix the problems that develop in the cancer cells themselves and sort of maintain their life. That these drugs are designed to block the ability of the cancer to repair itself.
right. I used to sort of describe it as a smart bomb. We
Right.
can figure out exactly what we should focus on, versus chemotherapy really is sort of a scatter bomb.
Yes.
You know, we kill the cancer cells, but then unfortunately some healthy cells are killed
Yes.
in the process. So
Right.
we are getting better about figuring out exactly what we need to treat. So you also mentioned cancer of the vagina and also the vulva, which is pretty uncommon, but could you address those just for a minute or two?
Sure. Those cancers are also probably related to HPV infections.
Okay.
And the vulvar cancers are the next most common below cervix cancer, and there may be 5,000 cases or so in this country. And the vagina is similarly, although somewhat less common than that. They're primarily squamous cell cancers that are skin-like changes in the growth of the skin. And those can be related, again, to smoking. They can be related to HPV. They can be related, in the case of vulva, to chronic inflammation. And women that have chronic atrophy and what we call lichen sclerosis, where there's a lot of itching and burning due to the atrophy and the low-grade inflammation in that tissue that leads to the irritation that develops into a cancer. So those are usually in an older population for the most part. And again, they're treated, at least in the case of vulvar cancer, primarily with surgery. And success rates, again, are very good if it hasn't spread to lymph nodes or beyond. So we have and that's sort of surface disease. It's surface cancer. So it's something that, you can diagnose yourself if you wanted to, because it's something you watch, and you just be careful to anything that feels abnormal or may look abnormal. Not that everyone's looking down there, but if it feels
Right.
abnormal, then you should have it evaluated.
Seek medical attention.
Yeah.
Right.
And the part of the problem is that women that do well and say don't need pap smears, they'll frequently not go to gynecologists to get an exam, and their internists or primary care doctors don't particularly like to do pelvic exams most of the time, so they don't get checked in that area, and some of those lesions can be asymptomatic without symptoms, and otherwise would have been caught earlier. So, and there's no, those are all women that are older and they don't want to be examined that way, and they all hate it, and we understand that, but it's still important that you get seen by someone at least every couple of years.
Right. Because early detection, again, means diagnosed earlier on
Yes.
in the game. So anytime I think the word cancer is involved, there's a lot of anxiety about what's going to happen. So what sorts of things do you talk to your patients about, and what types of questions should they ask you when they come in to see you?
Well, I've sort of developed over the years an approach that anticipates the questions that they may have, and you spoke about early on about women not knowing what these cancers are. I mean, I tend to draw a lot of pictures and show them what their anatomy is, because a lot of women don't understand where things are and how they interrelate, and I think that's helpful for the patients. And we talk about what the biology of the disease is and how we approach it because of the biology of the disease, and then try to be as optimistic and reassuring as we can, because there is a lot of optimism in what we do. We cure a lot of women, but we can't cure everyone, and we try to basically make sure that they are clear on what they're going to face and go through, and that their questions are answered. And for us, I think it's helpful because we can tell them that we're your primary doctor as far as your cancer goes, and you don't need to go to 4 different doctors to be treated for this cancer.
Right.
You're coming here.
Right.
And the nurses get to know them well, and I get to know them well, and it's just it's a sort of a continuum through their care,
Right.
which is, I think, very helpful.
Well, and that brings me to symptom management. When I used to talk to patients, I would say, don't suffer in silence. Pick up the phone, and now we have the advantage of patient portals where people can go through the patient portal and they ask a question. Because I said, there could be something that the medical team can do for you.
Yes.
Whether it's nausea from chemotherapy, or if it's fatigue, you need to evaluate what is it, poor nutrition causing that. So
Right.
it sounds like your team stays very involved in the patients' lives to sort of get them through.
I think we are, and we see that there are needs beyond what we can do, and we're starting a program now which we're going to call lay navigation, where we'll have volunteers that will sort of partner up with the patients and be their advocate, if you will, for issues that they may have, and try to sort of bridge the gaps that may exist between the patient and the physician. They don't, patients will complain, or family will complain to the nurses all the time when they see me that they don't complain very much. But we want them to complain. We want to know what their
Right.
problems are. We
Right.
want to know what their issues are, and those issues go well beyond how they feel. It may be their financial situation or
That's
their
correct.
social situation, and they're taking care of 3 grandchildren, and their parents are out of the picture. All those things that impact on how well a patient feels and how well they can deal with the stress of
Right.
their treatment. We try to identify that, and those are the things that we need to work better for, and try to and screen the patients, not only initially when they come in to be treated, but through the process to see how they're doing. And historically there's studies that looked at that, and women generally do get better or feel better about themselves through their treatment. Interestingly enough, their spouses tend to go down in terms of how well they feel. So it's, and women pick up on that stuff. I try to tell my patients all the time that, you're always going to be caring for the other people in your life more than you care for yourself. But you have to sort of forget that and consider yourself to be the primary person now, and they'll deal with it, you know what I mean? But they'll do things that they feel they need to do because that's what they're expected. They think their husbands expect, or their, significant others expect, or their children expect, when they really don't want to do that. And complaining is one of those things. So, we try to tell them, if you're having a problem, let us know about it.
Right.
And we try again to anticipate what problems they may have, and make it easier for them to report on that. And as you said, those portals and so forth, they can email us, they can text us, and there's a lot of ways they can get in touch with us now.
Right.
And we're looking at pictures that they can send us over the computer that says, well, I've got this, here's my port where I get my chemotherapy. It's red. What do you think about it? And they'll send a picture.
Right.
They don't have to come into the office to be seen. So there's a lot of things that are moving forward, but we constantly have to remind ourselves what we're doing here, and everyone's an individual. And as I was going to say earlier, that cancer is unique to that person. It's not just ovarian cancer. There's a lot of different ovarian cancers, and everyone's cancer is different than the next person's. And even within their own cancer, there's a lot of different biologies that are going on that you can treat a part of that, but the other part of it we're not treating. So it's, with those cancers are so heterogeneous and so variable that it is hard to find the one smart bomb that's going to go in and knock out the whole cancer. It may knock out 80% of it, but those other 20% get away, and then they're the ones that come back potentially. So it
may take a combination of therapies in
Exactly.
order to be smart about the treatment. So speaking of that, what sorts of new research is on the horizon in the realm of GYN oncology?
I think the biggest thing is what we mentioned before, and that's the genomic testing that's been going on, and the ability to take a cancer, have genomic and proteomic testing for those cancers, and see what abnormalities exist within those cancers, and then identifying targeted therapy for that. I think that's where most of the research is going, and it's progressing in an incredible way. There's it's not just GYN cancers, and there are other cancers where this is working as well. But I think that's where the future is, as far as cancer treatment goes. It's not trying to look at napalm to clear the forest. This is about trying to selectively target the cancers as they should be, and avoid other trauma to the body that we hopefully can prevent.
Right. And
or
the cell's
avoid.
very complicated. I think more complicated than any of us knew. So.
Exactly, and it's always changing.
Yeah.
That's the thing, is it's always sort of mutating. So
That's right.
It's difficult, but I think that there's, like I said, the treatment that we have. When 30 years ago when I started, there were basically 2 or 3 drugs that you could use that was effective at treating ovarian cancer. Now we have 3 times that number, or 4 times that number, and we can control the disease for a number of years. 50% of women with advanced ovarian cancer are likely to live 5 years, and most of those, as I said, are going to die of their disease. But there are long-term survivors that can be treated for recurrences, and they can be treated for up to 15 years or longer. in and out of therapy because they have chemosensitive disease. And then
Chemosensitive disease being,
disease that we have a treatment that's effective for it. And a
so
lot
it
of that.
staves it off for a while, and
Yes.
then they can go without any chemotherapy
Correct.
for a while.
Correct.
Okay.
So they're in and out of remission, so to speak. And that's, you know, that's a good thing because most of the time the quality of life is good within that time period. And you never know who's going to be do well with the treatment. And even in the most advanced cases, you can see women that respond very well and be cured. So my theory is to always be as optimistic as you can at the outset, albeit not giving undue optimism, you know, and you have to state the facts, and most people know that. And the nice thing is that, you know, women and most patients are very savvy about their disease. They know where to find information about the disease. Talking to friends is always helpful, but, you know, I caution them about taking too much to heart at that kind of thing. But there are a lot of support venues in place throughout the internet and even locally where women can get support from other people.
Right.
And I think that's a tremendous help for patients now. They get a lot of security from that. So that's always a good thing.
So you mentioned some online sources. Do you have any sort of validated websites that you would send women to look at information?
My my thing is primarily to look at the website that we have from our Society of Gynecologic Oncologists, which is the Gynecological Cancer Foundation website, which provides a lot of information for patients about their disease. I think the Mayo Clinic has a wonderful website for most diseases.
In your
and they do a
professional
good
society,
job.
what are the initials? It's probably initials on the website.
Well,
Do you know?
I believe it's gcf.org, gynecologiccancerfoundation.org.
GCF.org and the Mayo Clinic.
And the Mayo Clinic, and most of the major universities do well. Johns Hopkins, Sloan Kettering, MD Anderson. You know, those are sort of the
Those
major
are the ones
centers.
that just treat cancer.
You're right.
Most hospitals that just treat cancer.
Yeah.
Right.
So
Okay.
you know, they all have very good websites, but primarily I think that the Gynecologic Cancer Foundation.org is a good website because it's developed and it's made for our patients by us as
Right.
subspecialists
Right.
in treating that disease.
And where would someone find out about clinical research that was going on currently if they were interested in clinical trials?
Well, we can certainly search that out for patients that need that, and we do clinical trials at New Hanover, so we are familiar with that. We don't do all of the phase 1 trials or that are done in some of the major centers, just because our volume isn't high enough to do that. But basically, through their institution where people are being treated, they can usually look that up for them. Or you can go onto the NIH websites and they'll list the
Just
research that's
cancer.gov,
going on.
I think that's their-
Cancer.gov or
cancer.gov.
NIH.org or .gov. Those will all lead you to ongoing clinical trials and say where those are.
Okay. So, sort of to summarize what you've talked about, there's a wide range of gynecologic cancers that you treat, and they all have different sorts of early detection, prevention, treatment, and then you typically would follow those patients for a long time afterwards. Is that correct?
Yes.
And then you mentioned some things for prevention, which were watch your weight, don't smoke, HPV vaccine, make sure to get your pap smears, GYN exams. And then I think importantly, you sort of mentioned listen to your body. If something's wrong, make sure and go to a medical caregiver and figure out what's going on. Is
Yes.
that right?
Yes.
So if you had some parting words of hope for the audience, what would that be?
Well, I think that the primary thing is that we are making advances in treating the disease, and we have now a way to looking at the diseases more closely and identifying treatments that are specific for an individual's particular cancer. I think that's probably one of the biggest things. I think we're identifying what the needs for patients are outside of just their treatment. That's important. And I think that, as I said, that having the right attitude and being optimistic about where you are is important. And I think people that have a good mechanism for coping and being optimistic and positive in their treatments will do better. So I think those are the important things, and to remember that there's always support there available for them, one way or another. You just have to seek it out, and there's people that'll help you.
Yes.
So I think that's the biggest thing is that we care about our patients, and I mean everyone has a a kind heart for cancer patients, just as they do for children of all nationalities. So it's something that we are, as humans, are good at doing for the most part.
Sometimes
People
you just
generally
have
are
to
good
reach
people.
out and say, "Hey, I need help."
I need help.
Yeah.
That's right.
Yeah. Well, thank you so much for all the information that you've provided our audience this evening, and I really appreciate you being here with us. And I want to encourage folks to go to the Hope Abounds website and also our app, as you can see other interviews that we've done. There is hope available for you through your doctor's office. Hope Abounds also offers education and patient advocacy, so that is another venue for patients and their families to take care of. Thank you very much.